about junk DNA. I'm really honored and thrilled that Dr. Palmieri and the research committee, after not very much deliberation, made the choice to have Dr. Melina Kibbe be our visiting professor for this year. I think you've all really appreciated her great and insightful questions, and it really shows the range of your intellectual thinking about all kinds of levels of surgical science. Dr. Kibbe was one of those sort of under the radar for a little while, rising stars in academic surgery not all that long ago. And she just quietly was doing, incredibly important work on nitric oxide in the early days of that time as a vascular surgeon. She did most of her training, both undergraduate and medical school at the University of Chicago, spent a lot of time in Chicago, later was a faculty member in vascular surgery there, where she developed, I'd say, the bulk of her academic career. And then she quickly sort of jumped onto the scene. She was selected by the president as one of the young up-and-coming, promising junior scientists in the United States, and a real honor to go to the White House and have that experience. She's a member of the Institute of Medicine, and most recently has taken over and really transformed the journal formerly known as Archives, but now JAMA Surgery, which has just continued to go up under her leadership in its impact factor. And what's interesting is how one person can make a difference in science. And the answer is really each one of us can make a difference in science by being open and willing to ask the questions. Why do we do things the way we do? Why do we think about using small kidneys? Why do we think about approaches to vascular malformations? And is there a better way? And if you just look at the history of surgery, and we've seen some of those in grand rounds, we are continuing to find better ways to do things. It matters what we do, and it matters to bring science and research into surgery, even though they like to think of us as the sort of non-intellectual discipline in medicine. It's not true. So it's really an honor to have Dr. Kibbe with us today, and she's speaking on a topic that's incredibly important and finding more and more traction in the world of medicine. As we think about precision medicine, we realized that so much work had been done previously just on men, first just on mice, then just on men, and that the differences in the way people respond by gender and perhaps even individually is incredibly important. So it's a great honor to invite Dr. Kibbe up here to give her presentation on sex bias in biomedical and clinical surgical research. And I want to present her also, if you'll come up, with just a small token, which we won't make you put in your suitcase to take home, of your time with us. So thank you very much.
Thank you. I love this. I know. Thank you. All right.
I'm going to stand on my tiptoes.
Wait, here. Come over here.
Okay.
I know.
There we go.
Thank you. Thank
Absolutely.
you.
We'll put it in front for your talk.
Okay. Oh, perfect. Thank you. And let me, I'm going to mic up here. So I have to say, let's see, the on button. Who knows how to turn this bad boy on? Wait, it's usually at the top. Here we go. Okay, got it. Is this one? Okay, perfect. Got it. Okay. I think that'll work. Okay, perfect. So I have to say, this has been a huge treat for me. So I was excited when I first was invited to come here for many reasons. I know so many folks in this department, and this department today has shown it to me that the research that you have presented today is exactly what you just talked about. It's really impressive. So, we as surgeons, I think impact is one of the things that most all of us strive for. And we as surgeons can have an impact on our patients on a day-to-day basis, no matter where you are, in the community, in an academic center. But the thing that differentiates everyone in this room, being in an academic center like this, is that you have the ability to impact the future delivery of care to patients with surgical disease. And many of you, you're already doing it, and many of you are going to be doing it in the future. And it was really impressive to sit through all these different talks today. So I hope you all appreciate what an amazing thing that you're part of by being in this department. So thank you. This has been a great treat for me, and thank you for having just so much vascular by chance, too. Now, what I am going to talk to you about today is not my own research. And this is a story that I hope you enjoy, although this is a room full of research. This is a perfect audience for this, but you're either going to love it or you're going to hate me at the end of this, because many of you, I think, are feeling the pain of this, but the pain is good. So with this talk, I will tell you I don't have any disclosures as it pertains to the material that I'm going to show you. So let me ask you this. Are these two people similar? Do we think they're similar? I think we know they're not. Do we think that these two are similar? No. What about these two individuals? Very clearly not similar, right? So that gets to the basic question that Dr. Farmer was just mentioning. So if they're not similar, then why is it that researchers study mostly males when developing therapies for both sexes? And that really leaves many high and dry. We know that men and women are not similar. We know this. And so here is a slide that shows some of the common differences between men and women that I think most of us in this room know. So men and women can manifest disease differently. I'll just remind you, one of the biggest differences is heart attack, right? We know men and women very clearly can present differently. They experience illnesses differently, respond to drugs differently, metabolize drugs differently, respond to devices differently. We certainly know that a hip replacement in a female is a very different thing than a hip replacement in a male. And men and women can have different outcomes following medical and surgical therapies. Now here's a slide that shows some diseases that have well-known sex and gender differences. Now notice throughout most of this talk I am referring to sex, so the chromosomal difference, and not gender, our phenotype by which we present ourselves. But so here's a list of some common diseases with known differences. So again, I'm a vascular surgeon, so if you look at this list, you got heart disease. So let me show you a couple facts about this. So this slide, I think most of us in this room have a general appreciation for. And this is a slide showing the incidence of cardiovascular disease by age and sex. And so you can see as we age, cardiovascular disease goes up, and most of us have an appreciation that men have a higher incidence of cardiovascular disease than women. But did you realize that more women die from the disease than men? A lot of people don't realize that. That's a huge difference right there. And then if I also look at some of the drugs that we commonly prescribe, at least as a vascular surgeon, look at this. So aspirin. We all know that aspirin is beneficial for prophylaxis for men. When you hit 50, it is recommended that you take aspirin for prophylaxis. It is contraindicated in women. And I will just tell you, when I hit 40, again, vascular surgeon, right? We love, right? Would you not? I put myself on aspirin at 40, only for my primary care doctor to yell at me and quote all the literature, so I had to take myself off of it. But she won, but I still love it. Statins. Statins, more beneficial for men for primary prevention, greater risk of adverse reaction in women. Angiotensin-converting enzyme inhibitors cause more adverse effects in women. Digoxin, associated with increased mortality in women. And warfarin, we all know that women tend to require lower doses than men. So these are just some common drugs that we're prescribing. But look at these known differences that we appreciate. So that brings me to this question. So then why is it that men and women are given the same drug for disease that we are all prescribing in this room? And why is it that men and women are given the same dose of drug for disease? Can any of you think of a drug that is dosed differently based on sex? And do not say a sex-based drug like testosterone. Or, yeah, nothing sex-based. Think about it. We all prescribe medications in this room. Can any of you think of a drug that we prescribe that is dosed differently based on sex? Yeah, well, if you watched did you know this already? Yeah, so thank you. Yeah, so you just named it. You just named really the only drug that is out there now, and that is Ambien. So thank you. We have one drug, you guys. One drug that now has an FDA-indicated different dose for men versus women. How did this come about? Came about recently in the last few years. Well, Ambien was actually approved by the FDA back in the early 90s, and same dose. But it was realized more recently that women the next day, now Ambien is a sleep-inducing drug, for those who aren't familiar with it, they were realizing that women the next day were getting into automobile accidents. So of course they investigated this and realized that the drug was still in the system and women were not metabolizing Ambien as quickly as men. So the FDA, for the first time ever, actually issued a label change. And we now have this one drug where 10 milligrams is recommended for men, 5 milligrams for women. But this is one drug. Think of all the drugs that we prescribe. It makes you start to wonder about this. Now I have to tell you, what kind of upsets me is that when you go and pull the actual new drug application from the FDA, and you can tell this is an old copy that we've dug up, this was from the early 90s, it was actually in the new drug application to the FDA. So look at this. They actually show when they studied 49 males to a whopping 16 females, they actually showed that the clearance was actually slower in females, and the area under the curve, as you can see right here, was also higher in females. And then the statement actually says both Cmax and area under the curve were approximately 45% higher in females than males. The results suggest a gender-related difference. However, the lack of specific details, such as study design and individual data, make it difficult to draw a conclusion. It was there in the new drug application. Yet, did the FDA ask for further study on this? No, they approved it as it was. So do I hold the FDA accountable for a lot of this? I do, and this is going to come up over and over again in a couple of different times, because I think there are a lot of things that we can be doing to actually impact this. It was in here. So how did we get to this point where we just have this one drug, but yet I showed you that list of all the drugs for cardiovascular disease with differences? Well, I think that many of us would agree that women have been poorly represented in clinical trials in the past. Sex-based differences have not specifically been sought out, and also sex-based differences have not generally been reported. Now, in the early 1990s, it was recognized that women were actually being poorly enrolled in clinical trials. And I think there's several people in this room who probably remember this when it was a big topic of discussion. Here's one paper that showed that only 55% of clinical trials published during this time period had both men and women, only 55%. And another study showed that less than 20 to 30% of the studies actually analyzed the data by sex. So this was recognized in the early 90s, and we actually had the Revitalization Act. So the Revitalization Act was signed into law in 1993, and this requires that women and minorities be included as subjects in clinical research. And that's important, clinical research funded by the NIH. So that's the law, and we've had that law since 1993. Now, how are we doing since we've had that law since 1993? Well, some more recent trials. So this is one that was published in 2011, and they found that now 76% of trials enrolled both men and women. So we did better, but women still represented only 37% of the enrollment. And then another trial that was looking at statins, and I showed you there's some distinct differences there. So we did have 19% women enrolled. Now we're up to 31%. And a study that looked at the orthopedic literature found that there was an increase in sex-specific analysis from 19 to 30%. So we still have a little ways to go when it comes to this issue. But now let's talk about the root of the problem. So if you look at this, this is kind of like the pipeline for drug development and therapeutic development. And so as we know, especially from sitting and listening to all the great talks today, is that research can progress from the basic stage of cell research up through animal stage, which would be your translational research, and then to your clinical trials, your human clinical trials. So the issue is this is where the Revitalization Act focused on. And in my opinion, this is one of the problems. And there has really been no focus whatsoever on the earlier stages of this pipeline development in animal and cell research. And one of the other problems with that is by focusing on the clinical trials, well, guess which is the most expensive spectrum of this? It is the clinical trials compared to the animal research and the cell research. So I would tell you that we've been focusing our effort on the end of the pipeline. But if we were to actually focus some of our effort on these earlier stages and by studying both sexes, we would then be better informed going into our clinical trials. And you may or may not know this, but the majority of clinical trials that we conduct are actually negative. So being better informed going into it could potentially help. So really the question is, well, does sex disparity exist in those earlier stages of the pipeline of basic and translational research? Because we've certainly had no focus on the inclusion of both males and females, no policies that have actually required investigators to study both sexes, and it's really been left to the individual investigator. And I did hold back today from, if I would have given this talk first, then everyone who was presenting probably would have noted if they were studying males and females. I held back on asking that question on purpose. But think about all of you who presented today in your research. It did come up in one talk about studying in males. But how many of you have been studying in both male and female cells and male and female animals? So we asked this question, and this is when I was at Northwestern. These are two of my vascular integrated residents, Neil and Dustin. We wanted to know if sex bias existed in basic and translational surgical research. And we hypothesized that it did. So what we did is we went to 5 of our common journals in surgery, and we abstracted data from basically every single publication in these journals over the 2-year period of 2011 to 12. And these were some of the variables that we abstracted, but the key thing is we looked at the total number of animals used in the study and what the sex was, and if they had cells, what the sex was, etc. Now, what did we find? So in this, from the 5 different journals that we looked at, there were a little over 2,000 articles, and excluding the articles on humans, was left with 618 articles. Now, I'm going to tell you that there were a lot of unexpected findings with this little study for me. This first one was a surprise because there are many people in this room who are peer reviewers. I was really surprised in modern literature to find that 22% of the papers did not state the sex of the animal studied. Are you not surprised? I was surprised. 22% in modern day literature did not state the sex of the animal. Now, of those that stated the sex, which is the 78%, here's the pattern. This is our surgical literature. 80% studied male only, 17% female only, 3% both. Now, what about cell research? So the issue is a little different. On cell research, 76% did not state the sex of the cell. And I see a shaking head. I get that a lot because people will say, well, I just bought the cell line from ATCC, right? Is that what you're thinking? And so that, yes. However, you can get the sex of that cell line if it's a cell line. And if it's a primary cell, so I work a lot with primary vascular cells. We grow our own endothelial cells and smooth muscle cells and fibroblasts. You better believe I know the sex of those animals that I grew those cells from. So you can state it. And I will also tell you that the sex of the cell in the Petri dish can have a profound impact on your experiment. So again, 76% did not state it. All right, well, what about the 24% that did state the sex of the cell being used in research? Same pattern. 71% studied male only, 21% female, 7% both. So that's not so great. So we then said, well, what about the investigators who are studying diseases that are prevalent in women? Are those investigators studying more females in their work? So again, that was the list that I showed you early on about diseases that are prevalent in women. So we said, okay, in our surgical papers, we could at least look at enough cardiovascular and thyroid papers. Thyroid, there's statistically many of us women in this room that have thyroid disease. So what did we find? So we have 45 manuscripts in this category. Of these, 44% did not state the sex that they were studying in their animals and cells. And of those that did, it was actually a little worse. 88% male only. 8% female only, and a little 4% both. And again, this is in diseases that are prevalent in women. And then the last question we asked is, okay, after seeing this data, we said, well, how are we doing over time? Are we getting better with this practice, staying the same, or are we getting worse with this practice? So we went back and abstracted data from all the papers in 2001 and 1991 to see how we were doing. I also did not expect this. We've been getting worse over time with our practice of studying male only in our research. So what are the implications of this kind of sex-biased research in our surgical literature that we're conducting? Well, there's many. So drugs could be developed that just flat out may be ineffective in women. Drugs are developed that may have unintended side effects in women. You saw that list of the drugs, the cardiovascular drugs, and all the ones that had unintended side effects in women. Drugs that show no efficacy in men may be dropped and not pursued, but yet they could have a benefit in women. And then drugs that are studied in both sexes, if you report it in aggregate, the results, that's great. But you still need sex-based reporting because you may have a drug that has more of an impact in one sex or the other. So now, and I have a room full of surgeon scientists in here, we get to this question. Well, why is it that investigators are not studying both sexes? And I'm sure many of you who do research are thinking about this right now if you have been studying single sex. So I can tell you these are some of the reasons that people, quote as to why they don't. So perceived physiologic and or behavioral differences between male and female animals. And also the fluctuating ovarian cycle with females, and that these could lead to unpredictable results. Well, I understand this. However, there's been large meta-analysis done on this and actually showed that this does not have a significant impact on the data. So I'm not sure that these are valid reasons, yet we all like to control for that variable. Now, this is true. It's more expensive to study both sexes. Flat out, that's true. And it's more time-consuming. True, again. And then I'm going to say that this is actually where I lived, and this will come out in a few minutes. Just a complete ignorance to the fact that there's a real difference with the two sexes. I never thought about it in my own research before. I did my postdoc, and I was told just order males, and I never questioned it. And I just always ordered males to control for that variable of sex, and that was it. Until I was challenged on this, and again, you'll see. Now, is this problem unique to surgical research? Absolutely not. There's not a lot of papers out there, but there's a couple. And so this one from Zucker and Berry, they looked at 2,000 animal studies. And these are just some of the disciplines, but it's that same male to female ratio. And then here's a paper by Taylor. He looked at 10 cardiovascular journals and saw that only 28% of the studies reported the sex of their cell. That's freakishly similar to the number we found in our surgical research. Now, what about human surgical research? So we wanted to know, what are the issues on the human side? So I showed you what we found on the animal and the cell side. So we went back, and this time we looked at the articles with human subjects published in those 5 journals. Again, interesting that in modern times, we have 17% of the manuscripts that did not state the sex of the human in the publication. That one, I'm not even sure how it gets by peer reviewers, you guys. Seriously, 17% that did not state the sex of the human. And then, this is what we found. For those that did state the sex, I was really happy to see this. So 78% did include both men and women. We, of course, have that 17% that is unspecified. And then, yes, there are a few single-sex studies, and some of these are breast and ovarian and prostate, etc. So this is good. And then we looked at the absolute number of men versus women, and actually found there was 51% female, 40% male. Again, I don't know where this 9% would fall, so they could end up being even, I don't know. So that's good. Now, let me show you what the 2 issues still are, though, with our human research. So this is one. We then asked, all right, for those papers that have both men and women, are they at least matching the inclusion of males and females? So meaning 100% match would be like 50 men and 50 women. And a 50% match would be like 50 men and 25 women. So this is what we found. So looking at, let's just look at, say, 90% match. Only 9% of the manuscripts had a 90% match. And only 45% had a 50% match. So I'd say this is one of the issues that we're facing. And then the other issue with our human, oh, sorry, this is just to show you by specialty. So you can look at your own specialty on here. And so you can see who are the ones that have a lot of males. So cardiac and thoracic, there you go, Cardiac and thoracic and peds have a lot of males over here. A lot of females are breast and bariatrics and endocrine. And then I think, where did vascular go? We have, unfortunately, here we are. So actually, we still have a good amount that's unspecified. Not so good, but you can see how your specialty did. But here's the other problem. The other problem is this. So we looked to see, was there sex-based reporting of the data? So when there were males and females, did they separately report how the men reacted to the drug, the device, the therapy, versus the women? And we found that in only 38% of the time was there sex-based reporting of the data. Was the data analyzed by sex? Statistically, only 33% of the time. And then lastly, was there a discussion of the sex-based data in the discussion section of the paper? And that only occurred 23% of the time. So these 2 things, I think, are still the current issues in our human research. And so much so, I was really happy when I saw that this came out. So this was the 2015 report from the GAO. This is the Government Accountability Office. And they actually recognized this very issue. So they said more females than males have been included now in NIH-funded clinical research, but despite the Revitalization Act of 1993 and the increased female enrollment, sex-based reporting and analysis of the results remains an area of disparity. So our government is acknowledging this is still a problem. This, to me, is the ultimate problem and the ultimate effect of this practice. Were you guys aware that 80% of the drugs are removed from the market because of a greater risk of adverse reaction in women than in men? 80%. You remember that slide I showed you with all the cardiovascular drugs and all the increased adverse reactions in women? Because again, if we're developing drugs and testing them mostly on men, this is what can happen. And we also know that the odds of an adverse drug reaction in women is 50% greater than in men, and that women are more likely to be hospitalized from their adverse drug reaction. So I think these are the implications of this practice. Now let me show you a good example. So I'm not showing you all the negative, the herpes vaccine. So this is a study from 2002, New England Journal of Medicine, sponsored by GlaxoSmithKline. And what they did is they found that the overall efficacy of this vaccine was 38%. Normally, an industry company like this would probably drop this and not pursue it with an efficacy of only 38%. But what they did was sex-based reporting of the data. And they found that it was wildly effective in females and not really effective at all in males. This was the ultimate genesis that led now to the vaccine that all teenage girls get. So this is an example of when it's done well. Now, how do we fix this problem? Again, Ambien, one drug. How many other drugs need to be evaluated? So I would say that we need increased awareness. We need increased awareness among investigators who are doing the research to actually think about this and to be very thoughtful about studying both sexes. We need increased awareness among physicians who are prescribing medications to patients of both sexes all the time. And then interestingly, we need increased awareness from our patients. So whenever I give this talk to a lay audience, it is amazing. I get the same reaction from a lay audience every single time. At the end, they're going to be like, well, Dr. Kibbe, I don't understand. If my doctor prescribed that medication, I just assumed it's been tested on both sexes. It never fails. That is the reaction from the patients, because they have just this implicit trust in us. So one thing we did is when I was at Northwestern and under Teresa Woodruff's leadership, she's the director of the Women's Health Research Institute at Northwestern, there was a group of us who were very concerned about this, and we wanted to try to have impact on this issue and to affect change. And there have been many groups. Do not think that we were the only group doing this, because there have been many groups trying to affect change on this topic. But what we decided to do was we went on this little campaign and we wrote to a whole bunch, because we knew that to affect change we needed a national platform on this topic that would get some serious attention. So we wrote to a whole bunch of different producers of TV shows, and we got really lucky because the producer for Leslie Stahl actually responded and said Leslie Stahl thinks this is a really important topic and wants to do a story on it. And so I'm going to show you a little clip from the 60 Minutes story. And if you want to see the whole thing, you can go to the 60 Minutes website and see the whole thing. This is just one small clip.
Early last year, the Food and Drug Administration made an unusual and surprising announcement. It cut the recommended dose of the most popular sleep drug in half for women.
I didn't do that.
It turns out men and women metabolize Ambien, known generically as Zolpidem, very differently, leaving women with more of the drug in their bodies the next morning, and therefore at a greater risk of impaired driving. Ambien, Zolpidem, is now the only prescription drug in the country with a different suggested dose for men and women. But we've discovered it is far from an isolated example of differences between the sexes we never imagined. More and more, scientists are realizing that the differences are dangerously understudied, and that pervasively and fundamentally, sex matters. A few years ago, Dr. Kibbe was using her male rats to study a problem that occurs in people.
You're going to show us?
She explained that after common surgical procedures like balloon angioplasty, which opens up blocked arteries, scar tissue often grows and blocks them off again.
And this is scar tissue right here?
Yes.
She discovered that a drug called nitric oxide could prevent that process in her rats.
She is one of our superstars at Northwestern, a tremendous surgeon.
Teresa Woodruff is also a professor at Northwestern Medical School and heads their Women's Health Research Institute. One day at lunch, Dr. Kibbe told her about the success she'd been having with her treatment.
I said, oh, well, that's interesting. What happens, what are the similarities or differences between males and females. And she said, oh, well, I don't study females, I only study males.
She says, have you studied it in females? And I looked at her, blank-faced, and I said, no, I'm studying it in male animals. She's like, Melina. And so she educated me.
Did she chastise you, or you ought to be ashamed of yourself?
All of the above. Yeah, and she really got me thinking.
Woodruff challenged Kibbe to go back and try her study in female animals, giving her a grant through her institute to buy the additional rats. Up until this lunch, did you, in your own mind, assume that male and females responded the same?
I did. I was shocked at the outcome.
I still remember the real epiphany moment when she came running into my office and said, there's a 180-degree difference between males and females. You know, that's powerful because that drug doesn't work the same in males and females, most likely. And so by uncovering this out of a lunch, we can change human health.
So that is a totally true story, except for the part I did not go running into her office. But it is very true. So Teresa really got me thinking about this, and she gave me a little small grant from her institute. And I'd been studying, as you mentioned, nitric oxide-based therapies to prevent restenosis after vascular intervention. And it's wildly effective in male rats, and pigs. And I went to go study it in the female rats, and I was really horrified. It didn't work at all. Zero efficacy when I looked at the female rats. I had to jack the dose way up before I actually saw similar efficacy in the females. So here I was studying this my entire career, and this one little thing, I just didn't even think to look at the females. And so that's why it kind of was a light bulb moment for me and made me realize how incredibly important this is. I will tell you the other funny story out of filming this. You know, when you do things like this, of course, all your institutional representatives and everyone's there to make sure everything's fine, right? Okay, so they're all there. We do this. Did you notice that I wasn't wearing gloves when I handled the rats? Well, let me tell you, the Northwestern Institutional, my VP of research noticed, and I got a call the day after this aired. I'm like, come on, everyone was there. No one said anything. So that was kind of funny. I should have been wearing purple gloves. So I want to show you, though, what happened after we finally got the national platform for this topic that we were looking for. And this goes back to that early poster session, right, when we were talking about making an impact on the kids that fall. Where is the person who presented that? Yeah, I was hoping you were going to be here, because you can have impact. And so this is what happened. The story aired in February. I have never seen the NIH respond so fast to anything. So in May, the NIH announced plans for developing a new policy that would then require investigators to report their plans for the balance of male and female cells in animals in preclinical research. So that was like, wow. I mean, have you ever seen the NIH react in 3 months to something like that? So that we were like, excellent. So we're going to get some motion on this. So we were waiting after May and waiting and waiting and waiting. And Teresa was amazing. She went to DC a lot. She was representing the issue a lot. Finally, in October of 15, so a year and a half later, is when the NIH released this. And for any of you who submit grants, this is where you're either going to love me or hate me for our group, because this is when they disseminated implementing rigor and transparency. And so basically, the policy now states that any grant that is submitted after January 25th of 2016, so that's just a year and 3 months ago, basically must include sex as a variable, and it is a score-deriving factor. So this was great, because we were finally having an impact with the NIH. So then what happened was interesting. So I'm currently sitting on a study section. Is anybody else here currently sitting on study section? Yeah, okay, so I would love to hear if your experience has been the same. So the NIH has taken it very seriously, and they have been, all reviewers on the study sections have to go through training on this, and it's not just sex as a variable, it's also transparency and rigor, and all three need to be addressed now in all grant applications. And so the June study section of last year was really the first study section that had grants in there with this new rule. And I found it fascinating. So here's 2 examples, and I know that neither one of these are from grants from anybody here. But this was fascinating. This was in my June pile. A grant actually said, we will attempt to use all male mice since the incidence of aneurysm development is higher in males. So they're actually stating there's a difference, that there's higher aneurysms in males. And that's why they want to study only males. So this is a huge missed opportunity. Because I would say here they're stating there's a difference. Why aren't they studying both so they could look at the mechanism as to why it is that the males are developing more aneurysms than the females? So I'm sure they, if they knew it was me as their reviewer, would not be happy. But this was one that was in the most recent pile that I just had in February. So another grant that said, since no known differences have been reported in graft hyperplasia by sex, we will study only males. Now, I want you to know there's actually a lot of literature showing that there's differences in neointimal hyperplasia between the sexes. So that statement right there is, oh, but even if there wasn't, that's not a justification for a single-sex study. So the NIH now, it's taking it so seriously that after the primary, the secondary, and the tertiary reviewer discuss the grant, and they get to the discussion of the grant, the SRA actually asks the primary reviewer, did the investigator address sex, transparency, and rigor on every single grant? So please, for those of you submitting grants, take this seriously and address this. So the NIH, hopefully we're impacting change. Now, I'm going to show you also what happened after the publication because it was kind of fun to watch. So we published the data that I showed you on the cells and the animals. And so we kind of were watching the pickups in the lay press, and these are just some of them, and it was kind of fun to watch the different pickups from this. And this one. Not going to read it. Didn't even know it existed, but awesome. So this was funny, but I have to tell you that one of the best pickups was actually this, because it was personally meaningful. So several of you in the audience know my husband, Marco Patti. He's a surgeon who's a UCSF, very close for 25 years. So he's Italian. His entire family's in Rome. He's the only one who's not there. And this one day, literally, his brother, Guido, called him up and said, Melina's in the paper. And sure enough, I made the Italian paper. And the reason it was meaningful is because Marco's mommy, who's 94, still alive, doesn't speak a lick of English. And we just got married a few years ago. So at least now she saw that the American that her son married was in the Rome papers. So this was personally meaningful. Because I'm the American. All right, now journals. So I think that journals have a big role to play. So on the journals really should require all authors to provide a description of the sex. You saw the data that I showed and the number of papers that didn't even report the sex of the human, let alone the cell and the animal. And if one sex is studied, then I think a justification statement should simply be provided in the manuscript. So to date, all 5 surgical journals have agreed to change their instructions, but hopefully soon all journals will have their instructions for authors changed. Now the FDA. So I definitely feel that the FDA can be doing a lot more on this topic. So I personally believe that the FDA should require all new drug applications to include the study of both sexes, which they do. Okay, that's already a requirement. But they should also require sex-based reporting of the data. Believe it or not, it is not a requirement with new drug applications right now. Now, I also think that the FDA should require all clinical trials to balance the enrollment of men and women. Again, you saw some of that data, and conduct sex-based reporting. Also, think back of that new drug application on Ambien, 49 men, 16 women. Now, the FDA, so the 60-minute story aired in February, and then in May is when the NIH announced that they were going to develop plans to develop a plan. And then what happened was in August is when the FDA came out with this. FDA action plan to enhance the collection and availability of demographic subgroup data. Okay, so this was an attempt to go in the right direction, but this really fell short of actually having any kind of impact whatsoever. And then more recently, last year, you gotta love this, the FDA came out with the Women's Health Research Roadmap. And they have 7 research priority goals. Guess what goal number 1 is? Advance safety and efficacy. Advance the safety and efficacy and reduce the toxicity of FDA-regulated products used by women. I thought that was their job. So, I don't know. Interesting. So yes, do I think the FDA has a lot more they need to do? Absolutely. If you want to see the gotcha moment, watch the full 60 Minutes Club, because there's the gotcha moment with the FDA on that one. Now, industry-funded research. So currently, there is no mandate or policy for industry-sponsored clinical trials. That Revitalization Act is only a requirement for NIH-funded clinical research. Guess what the majority of clinical trials are funded by? Industry. Yet they don't have that mandate. So I personally think that the same guidelines that apply to government-funded research should apply to industry-sponsored research. So the only thing that industry is really held accountable to is when they submit the new drug application to the FDA. So again, it gets back to the FDA. And then lastly, the government. So the government, interestingly, after the 60 Minute story and the NIH, and then I'm not sure if I'd say anything with the FDA, but this congressman from Tennessee, I didn't know him, but Jim Cooper, basically proposed a new bill, Research for All, Act of 2015. And basically in this bill, there are requirements for both the FDA and the NIH about balancing the enrollment of both sexes in all of our research. And I keep checking the website, and this was the most recent one. There's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 who've signed on for this. So I really hope that this actually does, the bill becomes a law. I'm really worried that it's going to get buried into something else and it's going to morph into something else. But when people ask me if there's anything that they can do, I say write to your congressman and have them support this. That's one thing that we can actually do. So what have I showed you in the last 40 minutes or so? Hopefully, I have showed you that sex does matter. And so with the research that I was showing you, our own surgical research is fraught with sex bias. 22% of our surgical research did not even state the sex of the animal. And when they did, 80% studied only male. And human surgical research needs better inclusion of both sexes. And the data needs to be analyzed and reported by sex. And we have to have an increased awareness of this issue, because it's only through increased awareness and thinking and talking about it is how we're going to actually affect some change in addition to those policy changes. And we do need, I think there's a great need for further policy change. And again, gets back to what I was showing you with the FDA and with industry. So I want to end on one last clip. And so it's interesting. Again, seeing how the timeline went with the 60 Minute story in February and then the NIH in May, and then 60 Minutes re-aired this story, and then believe it or not, shortly thereafter, all of a sudden one night, I was coming home from the airport and I started getting some text messages saying, "You're on the Colbert Report." I'm like, what? I totally ignored it until actually a couple days later, I was like, oh my God, I was on the Colbert Report. So I'm going to show you this clip because he did an amazing job on this story, and let you see what you think. Let me turn this one up.
Mindless adoration, folks. I need it. I want to thank you for singling me out for your applause. It makes me feel special as an individual. Because frankly, I'm sick and tired of hearing about equality. Equality rights for gays, equal pay for women, equal space for equal. And now, Obama's equalocrats over at the National Institutes of Health are directing scientists to perform their experiments with both female and male animals. Co-ed lab rats? That's a bad idea. You just know late at night they're going to hook up at work, then it's going to be awkward around the water bottle the next day. You see, traditionally, folks, when scientists tested drugs on mice or rats, they were usually male. Seems natural enough. The female rats are all being used to test cosmetics. But, looking good. All right. But of course, there's another reason the female rats were left out of the experiments.
Turns out female rats also have those pesky hormones.
So to control for that variable, most researchers study just males.
You gotta leave the females out. Any scientist knows it's crucial to eliminate extraneous variables, like half the global population. But apparently, folks, turns out that omission created a few whoopsie daisies, like Ambien dosage. Ambien was put on the market after extensive testing 20 years ago, but just last year, the FDA told women to cut their doses in half because new studies showed they metabolize the active ingredients more slowly than men do. Unfortunately, a lot of those women didn't hear the FDA because they were asleep for some reason. And now, they're blaming the rats.
Not studying both male and female animals results in more problems for women down the road.
If the whole darn pipeline is male-dominated and sex differences truly do matter, how can it not be the case that you're going to end up with, on average, a lot more negative side effects in women than in men?
So, women should be grateful for bonus side effects. I mean, this time it's being sleepy, but next time it might be invisibility or heat vision. And this long-standing tradition of testing on only male subjects is based on the underlying assumption that females are simply a variation on a theme. Folks, that's science. Male is default human. All right, if you want bells and whistles like the bumpy bits in front or all that fancy plumbing down there, it comes at a price, ladies. For instance, we don't make medicine for you. And after all, how are we supposed to? Women are too complicated. That's why they're not allowed on boats. Their gyno pieces make compasses go crazy. Don't believe me? Then why are their insides shaped exactly like the Bermuda Triangle? Lost a lot of good men in there.
So, with that, I just want to thank you. It's been a wonderful day, and I'm really looking forward to tonight, and thank you for having me. And I'll take questions if anyone wants to ask any questions. Yes.
I thought that was fantastic. It really not only changed the way we do things going forward, but raise the point that we should
No, and you're getting on kind of the gotcha question that was in the 60 Minutes piece. It was, asking the FDA, well, if this happened with Ambien, how many other drugs out there should be dosed differently based on sex? Are you going to go back and look at drug applications? And they basically said no, they don't have the manpower or the time or the resources to do it. Human health we're talking about. I know.
As you know, plastic surgery is guilty of sex-biased research. The vast majority of my patients are female. Do you have any guidelines within your own department for surgeons who are conducting research?
Oh, no, that's interesting. So there are some things that are just going to be limitations. If you are studying a disease that is predominantly in women, then I would say your research should reflect that. Okay, and so if you have a female predominant thing, then you may be studying more females than males. One thing that's brought up often is what about the VA? And so unfortunately, the VA is the VA, and it is, about 90-95% male. And so if you're doing research using the VA database using the VASQUIP database, I mean, it is what it is. But I would encourage you, if you are doing research and using the VA database, to also then go and use NISQUIP or the NIS or whatever, because the VA is a very special population, and it does have very unique needs, but we just know that it doesn't always translate to females. And so just be aware of that. I don't have any mandates myself in the Department of Surgery, except for the fact that, again, whenever I am asked to give this talk, I say yes every time, because I feel that it is a duty of mine to keep increasing awareness of this topic. And again, you saw my own ignorance. I was studying males, and it was very far into my research is when I finally studied it in both sexes, and it was eye-opening. So yeah. Well, I would say that's incredibly important as well. So whether it comes to race and ethnicity, I will also say age, and I will also say weight. So I think all of those are really important. We as a group sat down and we decided, though, if we were going to try to have impact change, we needed to stay focused on the single most basic variable, as Colbert said it, right? We have two sexes, that's it. And, you know, Dr. Farmer was pointing out to personalized medicine. How can we ever reach an era of personalized medicine if we can't even get the basic variable straight, sex? So I would say that all of those are important. Race, ethnicity, age, and weight. It's just we wanted to focus on one variable first to see if we could have an impact. Yes. Yeah. Industry.
And are there other layers, for instance, IRBs at universities or health.gov or, you know, that nature entities that could, you know, not allow you to register DSMBs?
Mm-hmm. Mm-hmm.
Not allow you to file unless you're doing that.
Yeah, so I would say so we, when I was at Northwestern, did approach both our ACUC and our IRB to see if we could at least, what they agreed to, is at least have on the forms, you know, if you're going to be studying both sexes, if you'd be balancing the enrollment, and if you'd be doing sex-based reporting. But to actually make it a requirement at a university level is a whole nother thing. I would say that we can all do our part. If you're sitting on a DSMB, please bring it up. And if you're doing any research with collaborators, bring it up. And again, that's where I think increased awareness really comes into play. I mean, how many here have been doing, you may or may not want to show your hand, but how many here have been doing single-sex studies for the most part in your animals? It was me, right? And so I hope now that you'll go, it doesn't mean that you always have to study both sexes, because now that I know that I have the difference between males and females, you know, for certain mechanistic things, then I could either do aggregate studies or I could still do it in single sex because I know I'm informed. But at least if you've never studied your therapy in both sexes, I would encourage you to, because you may find something very interesting. Yes.
And there's a lot of database work where you can separate people by sex, separate people by race.
Can or cannot?
Can.
Yes, can.
And so we see these different outcomes between the sexes, and we see these different outcomes between the races. And sometimes those are non-changeable variables, though.
Mm-hmm.
So when I see these differences in outcomes, I sometimes question, well, how is it going to change my practice? Or
Yeah. Mm-hmm.
Or I can't change them from Hispanic or male to female. We have these kind of large data sets that show differences in the sexes and the races. What do we do with those outcomes?
Mm-hmm. You need to be aware of the results. I think that's critically important. But we have to remember all those database studies are exactly that. They're database studies. It's not a prospective randomized trial. So can it inform your future work? Absolutely. And I think there's still important stuff we get from the database work as well that should be informing our, you know, clinical care that we are delivering to our patients. So it's very important.
I was going to say Dr. Palmieri's study that you presented was probably 80% male, but that reflects the disease. So
Yeah.
I propose that the study should reflect the percentage male, female disease, or try to make it equal.
Yeah, I think it's a complex question. In the ideal world, it probably should reflect the disease, but I'd like to just get to equal. We're so far not even close to there. So I think that could be hotly debated, right? But again, burn injuries do occur in women. And as I understand it, actually women have worse outcomes. Am I correct in what Bruce has educated me on? And so I think it's critical. Are you shaking your head? But I've learned a lot since I've gone to North Carolina about burn and inhalational injuries. But yeah, they're very different, and I think it's important to study both. Is it not different here? Are women women fare worse here? Okay. I was gonna say if that was a North Carolina thing. Well, thank you so much, and I look forward to the dinner tonight. Thank you.